K. And they said there are no studies, therefore it shouldn't be a blanket protocol for all babies. I cannot believe a medical professional is saying the warning label doesn't matter. Wow, eat the Tide Pods then, per the recommendations of this guy who says warning labels and side effects don't matter. So first of all, please don't eat any Tide Pods. I never said that. What I actually said was there are no studies that demonstrate any negative side effects from vitamin K. There are not. There is only one reported case of a baby that had a vitamin K related anaphylactic reaction, and the baby did fine. On top of that, everybody kept bringing up the black box warning, but the black box warning is for adult dosage in adults who are in a traumatic situation that necessitates getting vitamin K, which is completely different from giving it to a newborn baby. So everybody that kept screaming about vitamin K in newborn babies was talking about a black box warning that didn't apply to the babies. And despite having to explain that multiple times, no one was getting it. What happens when you don't ask questions? So I'm Dr. Rahi Victory, reproductive endocrinology and fertility specialist, and we're going to talk about what happens when you don't know what's going on and don't ask the questions, and also don't advocate for yourself. When you're going through fertility, most people have no clue what's going on. They're at the fertility office or doctor in order to find out what's wrong. So number one, you deserve answers. There's going to be testing, and then there's going to be results. And if you're not getting those results explained to you in language that you can understand, then you won't understand what's going on. No matter how good a job we do helping you get pregnant, if you go through the process without knowing what's happening, I guarantee you it's going to have some degree of trauma, emotional, mental, or financial, because you didn't know what the steps were, why they were happening, when they were happening, how they were happening. So it's really important for you to understand exactly what is wrong with you. How do you do that? You got to ask. Should you have to ask? No. In a good fertility office or clinic, the doctors will know enough to advise you on every single thing that's going on with you. Here at Victory Reproductive Care, when we get your tests, I literally read them out to you line by line, explain what each and every single test means. You need that level of care. Why? Because like I said, if you don't get that level of care, you're walking away confused, frustrated, possibly annoyed, and definitely anxious because you don't understand what is going on. The other part is that when it comes to treatments, you need options. No one should be told this is the only thing you can do, because there's always options. Options might be as simple as no therapy or IVF, or it might be no therapy, IUI, IVF, and surgery. There's loads of options. There you go, Dr. Well, hello, everybody. Welcome to Fertility Fact or Fiction, the greatest show on infertility on the internet. And I am Dr. Rahi Victory, double board certified reproductive endocrinology and infertility specialist. And to my right is the wonderful Tarek Ibrahim.
Hello, everybody. Welcome to the show.
My dear friend and good guy, all things social media. No great studies to share. It's been a total lack of good studies forever. I don't have anything exciting or super cool to share in that regard. I will say two things that are important. Number one, we are more than halfway through our new funding allocation, but we do still have some funded spots. So if you are in need of IVF and you want the very best, please don't hesitate to let us know, because we do have funding we can use straight through till March. So if you are in any community, you do not have to be in Windsor, Sarnia, Essex, Chatham, anywhere like that. Just let us know that you want to do IVF with us, and we will have funding for you. In addition to that, our first in vitro maturation procedure happened on Saturday. And thanks to my incredible team and the amazing technology that we are using, we were able to take a 44-year-old woman's immature egg, mature it, and fertilize it. And it successfully fertilized. So fingers crossed, we're going to get a very cool outcome. This is a world first as far as we know. Nobody has tried it with the specific protocol that we are using. And so I'm very stoked about what this means, because this could be a total game changer. So very excited about that. And also huge thanks to my incredible team.
for all the work that they are doing, because it is paying off in spades. We're getting loads of people pregnant, and the volumes just keep increasing, which is great for our little family of people here. And that's been going well. Also, for those of you who are looking for really great PGT, I will say that Adam, who runs our PGT department, has had only 1 out of over 300 cases where we got no result. And that one result was from a very, very bad embryo. On every other one, we are not getting any patients that have no results, which is really impressive, because most of the time it's like 4 or 5% with other groups that do PGT. And in fact, the company we used to use, we actually had too many, we felt. So we're really excited about the fact that our PGT is doing better. So we do offer PGT for other places. And if you want to get a better read at a cheaper price, let us know, because we will be happy to help you out. So a lot of stuff going on, some very cool things happening, and we will see what exciting stuff happens for PGT. We also are excited to be bringing a embryologist from around the globe to come and join our team very soon. We're going to see how she does. So we're excited about that. She's coming in 2 weeks. And so very, very excited about everything that's happening, and looking forward to a very, very bright 2026. So, and Tarek and I feasted on some very good Indian food tonight. Yeah.
It was good.
It was good, wasn't it? Absolutely. It was amazing. Yeah.
Delicious.
Yeah.
Love it.
What's it called? Royal Spice.
Royal Spice.
Yeah. And we don't get free food or anything. So when we compliment a place, it's because we paid for the dinner and it tasted good. So,
there's a whole bunch of videos now where there's a trend where they're like, okay, influencer goes and eats the food. Food's terrible. They can barely finish the food. Then the owner of the restaurant goes to them and says, hey, would you like to make a video about this? And then they take the same video and like, oh, this was the best salad I've ever had. And they do a whole thing about it.
No, that was good food. For Indian food, it was good. And I still have my taste buds, which is nice, because usually when you eat Indian food,
a lot
taste
of trouble.
buds are gone. Yeah.
A lot of trouble.
A lot of trouble. Yeah. Cool. All right. So tonight we're going to take your questions. And if you have any questions about anything fertility or OBGYN, don't hesitate. Tarek and I were making a couple of videos. We've got an educational video about endometriosis because my daughter Jenna asked us to make that. Hopefully some of you saw the little rant I had about the lawyer that said that it was harder to be a lawyer than to be a doctor. My son sent me that thinking that he was right because he's a lawyer. And then got
found out he was wrong.
And then he got upset that I had
responded?
the response. Yeah. So Matt, I still love you. Nassim is a lawyer in training, so Nassim, I love you too. But yeah, it's not even close. You guys don't know what you're talking about. You're on crack if you think it's harder being a lawyer than a doctor. So we do have opponents. And for those of you that haven't seen that video, please watch the video and please like, comment, and share, because that video absolutely deserves to go viral. So I'm hoping that it will. In fact, I would like to ask you all to go watch that video right now, like, comment, and share. And maybe even while we're watching the show, we'll see it go viral. That would be very cool.
That would be hilarious. Yeah, it's a good video. The greats, Dr. T and V.
There you go.
My doctor refused. This is how it starts.
Uh-oh.
This is
yeah.
These are always my favorite videos when the doctors refuse.
I know. Yeah.
The doctor refused your protocol.
Oh.
It's even better now, actually.
Ouch.
And agreed to Lupron 3.75 with month 1, no letrozole, and month 2, add letrozole. They also said suppression and no suppression makes, you ready for this? Makes no difference.
Is there a question or is that just a comment?
It's just to let you know what the world is like out there.
Yeah. Well, it's a harsh world. Listen, your doctor hasn't read the evidence. I mean, the evidence is clear that Lupron and letrozole is beneficial. So if they're trying to give you just Lupron, you need to ask them for studies. Tell them to show you studies that demonstrate that just Lupron is beneficial, because I'm not aware of any that show that. It's like the people that are telling their patients to take Oralissa. There was like, I don't know, a good 6 months where we kept
a bunch of them all day, every day.
All the time. Oralissa. And then it was norethindrone. And we heard about that too. Like these
It's
just,
almost as if there's somebody going around with a bag of medicine and they're like, hey guys, use this week.
it's so true. And those just don't work. There's no evidence. There's no support for that. Someone asked me today, what do you think about Rieco, which is the same drug as Myfembree? It doesn't work. There's no proof for that. So the only thing there's proof for is Lupron with letrozole. And then we strongly advocate for other things as well, all of which individually there's proof for. There's no summative study of all the different things, but individually we know they all work. And when we put them all together, patient after patient sends us a message saying it worked. I just got a message via email with a whole bunch of pictures of a lovely patient from Australia who used our protocol and sent us a message saying, I wouldn't have this child having their first birthday if it hadn't been for your protocol. We get these all the time. So we know that it works. We know that it's better than anything else that's out there. And it's been incredible for us. So we're super excited about that.
Dr. V, got another great question here for you.
Okay. As long as it's not era, I'm good.
No, not yet. That wouldn't be classified as great. That'd be like, guess what? You know what I mean? That'd be a whole different intro. Yeah. My egg retrieval is this Thursday.
Okay.
And it's conscious sedation.
Yeah.
I'm super nervous about this.
Oh.
What's the process like? I'm at your clinic.
We give you an IV. We ask you questions to determine how much medication you'll need. We kind of titrate the amount of medication to what we think you'll need, and then we administer. Once we administer, we wait until you fall asleep. If you're not asleep, we just give you more. We don't proceed until you're comfortable. Occasionally, some patients will wake up or just say they need some more, and we give them some more. But generally speaking, no patients complain about pain because they're either asleep or they've forgotten everything because the medications we use are amnestic. So even if you did have some discomfort, you won't remember that you had discomfort. And we generally speaking don't have anybody shuffling or moving or yelping on the table because of the fact that we give you enough drugs to keep you very, very comfortable.
From TikTok, since there's so many of you guys on there right now, we decided we're going to hop over to the guys on TikTok.
Yeah.
Guys, gals, whoever.
Right.
You know,
we actually have a surprising number of guys that watch the show.
I'm not actually surprised. Things. Why would we be surprised about that?
Surprised. So I looked at our
No, we are cool guys, and people are watching cool guys. Okay, yeah, no. Well, this is a cool show.
It is a cool show.
That's it.
I will give you that.
That's it.
But it was surprising to me to see how many guys were watching. It was like 30-something% were male.
Oh, that's actually crazy. That's a huge number. Yeah, that's huge. 30%.
Yeah, it was a lot.
That is a lot.
It was a lot.
You know what?
I was surprised.
You're right. That's a lot. 30%. You know, I was thinking
huge.
You know, you saw one post comes out, you see a couple comments, you're like, okay, this is good. 30% huge
numbers.
Huge numbers.
Yeah.
It's all those little swimmy videos. They're getting excited. The boys are getting excited. Boys, they're boys, all the boys. The boys are getting excited. Hey, doctors, history of gastritis and endometriosis. So gastritis is in the movie Marry My Husband.
Oh, is it?
So this is actually like the plot. The whole movie's around this gastritis thing.
Gastritis?
Okay. Yeah. But it's got nothing to do with gastritis, but it's a big part of it. Whoever here has seen the show Marry My Husband, let me know. I'm trying to convince Dr. Victory. I know you're thinking, Tarek, you're such a masculine, handsome guy. Why would you ever recommend that show? I got a soft spot, guys. I got a soft spot. Tarek's have emotions, you know? So anyways, Marry My Husband. I'm trying to get Dr. Victory to watch it. He's apprehensive about it.
I can't even stay on this show.
It's a good show. You like that intro, eh? Guys, thank you for watching Fertility Factor Fiction. It is our honor to entertain you for this 1 hour. You know, we're having fun here. We hope you're having fun. If you are watching Marry My Husband, let Dr. Victory know that it's a good one.
I want to know if it's a good show. I'm currently watching Landman, but anyways, go on.
Another level of this show. Anyway, back to the gastritis here.
Yeah, gastritis and endo.
Gastritis and endo. Should prednisone still be used or avoided?
Oh, good question. With gastritis, probably not, because if your gastritis is caused by an infection or an inflammatory process,
The prednisone could make it worse. For example, if you have H. pylori based gastritis, you cannot take prednisone because it would make it worse. So no question, you'd have to be very cautious about that one. Don't just jump into it.
I just want to see if anybody recommended the show along with me.
Yeah.
I think it's dynamite. If you guys haven't watched Marry My Husband,
Watch the show.
I'm telling you.
I'm a landman guy. Anyways, go on.
All right.
Next question.
I'm looking. It's just I scroll too far down. You're loaded today. You're loaded. It's a big show. It's a massive show right now.
You. All right. Fire.
Yeah. Okay. So sorry, TikTokers. I'm coming back to you guys. We're still on TikTok. King T and Dr. V. Other than protocol and supplements, tips for successful transfer.
Exercise, healthy diet, loads of supplements, which are important. Probably measure your levels. Get your progesterone levels measured. Many places don't do that. I mentioned that on the recent post with the little kitty cat that fell over. I love that post. No one bit into it. The tiger post did great. 430,000 views. The kitty was so cute. No one went for the kitty.
Nobody went for the kitty.
And then yoga. Yoga's been proven to be beneficial. Have lots of sex. That helps too. So those are the things I would do.
Those are things I would do too, to be honest. Dr. V, when preparing with supplements prior to TTC, is there benefit to supplementing sooner, 6 to 9 months prior TTC?
Not any evidence that I'm aware of that would show that duration is necessary to see a benefit from the supplements. And in physiologic terms, there aren't very many supplements that take that long to sink in. The only one that kind of needs that for that long would be coenzyme Q10. You do need a fair bit of time for that. But aside from that, no, not at all.
How long before the day of transfer would you IVIG if one was doing it?
Usually like 5 days before is when we typically will do that.
Hi, doctor. Should I do PGTA before transfer? I'm 28.
No. There's absolutely no evidence anywhere that a 28-year-old doing IVF for the first time would benefit from it. There are a couple of exceptions, and I think it's important you hear this. So number one, if you are 28 and you've previously done IVF and had failures, yes, no question, you should probably do PGT. Number two, if you are 28 and you make like 20 embryos, it's going to be damn expensive to do PGT. However, you would be wasting time after time after time going through those embryos without knowing which ones are normal and which ones are not. And studies do support the fact that you can get pregnant faster if you have done the PGT. So there is some benefit to doing PGT in those cases. The other group is the group that has had either recurrent pregnancy loss or recurrent implantation failures, because that group of patients also will benefit because you know that the embryo is normal. So there are a couple of like sort of subcategories of patients that will benefit from this. But overall, for the general 28-year-old first round of IVF, no history of recurrent pregnancy loss, no genetic problems, no cystic fibrosis, things like that. No, there's absolutely zero benefit to you doing PGT. And that's coming from someone that owns a PGT lab now. So don't do that. It would make no sense.
So somebody responds to the show, Marry My Husband is the coolest.
Oh, really?
But then somebody says Landman is the best.
Oh, Landman is the best.
So we're kind of tied right now.
Okay. How many people out there who watch Landman agree that his wife, who is played by Ali Larder, and I cannot remember her name, is very similar in many ways to the character Beth from Yellowstone? I love both those strong, amazing female characters, and Ali Larder is so good in that show. So I want feedback. How many people agree that she's very much like Beth?
I'm not going to scroll just yet. You guys have a couple seconds to answer. Otherwise, I'm going to lose my spot here. Dr. V setting me up here.
Yeah.
Dr. V.
Yeah.
I got a great question here for you.
Okay.
You're going to appreciate this quite a bit.
Okay.
Don't get mad at me. I am just a messenger. Ready?
Okay. Yeah, I'm ready.
My Receptiva TX was positive.
Yeah.
Okay. So now,
yeah,
my doctor wants me to only do Lupron for 2 months.
Oh God.
Should I push from my doctor to also add letrozole?
Yes.
So receptive is useless, first of all. So I wouldn't do anything based on the results of that. But if you are going to believe that you have endo based on the receptiva test, then taking Lupron alone makes no sense. You shouldn't push, you should demand. I always don't understand why patients talk about pushing or asking for or whatever. It's your fertility journey. You're in charge. If you're not getting what you want, take your money and go elsewhere. We have bucket loads of patients coming to us from all over the world, Canada, the US, the UK, Europe, as far as Australia, New Zealand. I've got someone coming from Nigeria. Like, we have people coming from all over the place because we listen and we do what patients need and also help them out with what they want. So, we just made a rant video about this patient that went to a Toronto clinic who refused to let her do DNA fragmentation testing unless she had already failed 3 times. You're going to wait for someone to fail 3 times before you do a test? That's insane. It's completely unhinged. Like, no one deserves that kind of treatment. And there's no justification for that for something like DNA fragmentation, which has many documented benefits, like reducing the incidence of miscarriage. So this is absolutely unhinged. It makes no sense whatsoever. And this would be a very similar kind of thing that we're talking about. You got to advocate for yourself and demand for yourself. Don't let the clinic take advantage of you. You are not a dollar sign.
Dr. Victory, any tips on low egg quality? My first round ended with 1-3 BB blast, failed transfer, 39 years old, PCOS.
Oh, wow. PCOS. So that's unusual. I would want to know how long you stimmed for, what dose you stimmed at. Did they use any priming? Did they put you on birth control first? What kind of trigger did they use for you? Single trigger, double trigger? What kind of culture media were they using? What sort of lab did they use? Look, there are labs out there that close on the weekends. Okay. If your lab closes on the weekend, they cannot provide you with appropriate care because your eggs are going to be either immature or post-mature, and there is no way to make it precise. So that's not something that you can functionally work around. It just doesn't give you good results. It's impossible to get good results with that. So if that's what you're experiencing, you need to go to another lab. So that's something I would be looking at too. With PCOS, BMI would be huge, like very, very critically important. If your BMI is too low because you're in the thin PCOS category, that can be a problem. If your BMI is higher than it should be, that can be a very significant problem for egg quality. Nutrition, diet, your insulin levels, your ANA levels we recently talked about. So all of these things can be critical and are important to actually determining what your egg quality is going to be like, what your outcomes are going to be like. I would want you to reach out to me and tell me exactly which clinic you worked with, what your results were, and then we would figure it out from there.
Dr. Victory.
Yeah.
My OB, the absolute best. We love you, Dr. Victory.
Thank you.
See that?
Thank you. That's very sweet. You know what? I love doing OB because it gives me perspective on the fertility patients and lets me stay on top of the game. That way I know what happens to the patients, what kind of experience they have once they're pregnant. Do they carry their trauma? How do they carry their trauma? I'm there to help them through those scary parts when they have a bleed or when they have a complication or when they're worried about preeclampsia. So I love being part of that because I think we just take better care of our OB patients because I'm seeing the whole spectrum from start all the way through to here's your baby.
Dr. Victory, the wife and the daughter are absolutely incredible. Landman.
Aren't they? They're the best. Yeah, I agree. The wife is, the daughter's hilarious because she's so ditzy. It's really funny. And
they're similar, but a little more ditzy.
She plays it the same, but it's like so well done. And the mom is just, Ali Larder is just absolutely amazing in that show.
Oh, wow. You ready for this?
Yeah.
You ready?
Yeah.
I got diagnosed with unexplained infertility.
Uh-huh.
And the fertility doctor, said, IVF is my only option.
Oh.
They're coming out of the woodwork
Yeah.
today.
How many of you think that IVF is the only option for someone with unexplained infertility? I would love to see that. Like, can you put up a poll? Put up a poll on YouTube, Instagram, whatever. How many people think IVF is the only option? There are many options for someone that has unexplained infertility. So, number one, we know that continuing to try gives you a 3.1 to 4.3% chance of success. It's very small, but it's still a chance. You don't have to do anything. Just continue trying, maybe clean up your diet, eat a little healthier, take some extra vitamin supplements, have sex all the time. You're going to get into that, 1 to 4.3% success rate. Completely reasonable. No reason not to try. That's number one. Number two, you can try IUI with pills like Clomid or Letrozole, also shown to be beneficial, somewhere between about a 7 to 10% success rate, depending on which study you read. You can do pills with shots, bumps you up to about a 15% success rate, even with unexplained infertility. You can do IVF, and IVF is a very good choice because you're going to get excellent results and you're going to have robust outcomes. And I think that's fabulous. But, and this is really important, you also have the choice to have surgery, because 44 to 90% of patients that have unexplained infertility actually have underlying endometriosis. And for those patients that have endometriosis, there is absolutely no question that if you treat that endo surgically, you're going to do better. Okay, so on TikTok, I'm going to ask the question: what number of patients out there think that unexplained infertility can only be treated by IVF? That is
So
absolutely
they have to choose
absurd.
between a happy face or a sad face.
Yeah, happy face if you think it's true, and a sad
face.
face if you think it's not true. It's completely unhinged to me to hear fertility specialists just come out and say things that are functionally, factually, are not true. They're not even in our guidelines. Okay, there's an ASRM presentation on the management of unexplained infertility. There is no way you can justify on any planet, for any reason whatsoever, telling a patient that IVF is your only option. That's absurd. And that's, in my opinion, censored. That's just wrong.
So most of your followers, I guess they're all educated in the school of Dr. Victory.
They're all saying.
So they're all saying, of course, no way. But there are some people that say yes way. And on YouTube, you got 89% of the people saying no way.
Wow.
So
yeah,
you're doing your part, Dr.
There
V.
you go.
You're doing your part.
We are doing our part.
We're doing our part.
They're listening.
Good. Listen. Everyone's listening. Everyone's watching. Hi, Royals.
Royals.
Yeah.
We need like a sound button.
I'm thinking we need to bring
Royals.
crowns. Oh, we could do that too. That's also good. I can roll with that. How much natural progesterone rise do you need to confidently confirm ovulation in a luteal phase protocol?
Well, in a luteal phase protocol? Oh, well, anything over 5 nanomoles per liter is generally considered a sign of ovulation. So that's what we look for.
Hi, Mr. T and Dr. V. Okay. I'll play ball.
Yeah.
But Mr. T's good. Sounds.
Mr. T, yeah.
You know.
Yeah, we got to give you a mohawk.
Yeah.
Okay.
It's a whole hairdo required for that. That's right. Had a polypectomy. Polypectomy.
Uh-huh.
This thing's, I can't get the right angle here. On cycle before FET.
Yeah.
Fully medicated FET failed.
Okay.
Right after failed, repeat hysteroscopy showed multiple very tiny polyps return, similar to acne. Reasons? Thoughts?
Your medicated protocol. Polyps grow because of estrogen. Stop taking estrogen. Proven to be the lowest chance of success and the highest chance of miscarriage. No one should be on a medicated FET protocol. No one. No one should be on a medicated FET protocol. The sole exception are menopausal women or women where everything else has failed. Otherwise, don't do it. Doesn't make sense.
Is there any benefit to taking Profertil longer than 3 months before a TTC?
Yeah. The longer you're on it, the better it is. Sure. There's great stuff. Every guy should be on Profertil.
Should they?
Yeah.
Every guy?
You and me.
No way.
Oh, yeah.
Every guy?
Probably better performance.
Come on. Better everything?
Yeah.
Really?
Yeah. It's good for the mojo. It's good for everything.
Good for the mojo is good for me, man.
Yeah. And good for Mervet.
Good for everybody. Good for everybody.
Yeah. It's great.
Really? It's not just a
Yeah.
fertility thing?
No. So remember, guys with weak sperm or weaker sperm have other health problems: earlier death, higher chances of prostate cancer, higher chances of colon cancer, more stress, more depression, all sorts of problems that go along with having weaker sperm. So when you take a sperm vitamin, male health vitamin, and you improve your sperm, you're actually improving your overall health.
Heard that, boys? Tip of the day.
Everybody go on some kind of sperm vitamin. Yeah.
Do you work in the hospital or private practice?
Well, I do work in a hospital. I'll be there all day tomorrow doing surgery, but I have my own private practice as well. So in Canada, it's not hospital or private practice. We have our own offices. We have a soon to be 20,000 plus square foot clinic here. And then we also have our hospital that we use for larger surgeries like laparoscopic open cases. And because I deliver babies, I'm in the hospital doing that, as well as gynecology. I was on gynae call for the weekend, so I had to take all the phone calls from Emerge and from people that needed help for emergent gynecologic cases.
Hey, Dr. V, I just want to say I have a consult with you in April.
Whoa.
Soonest we could get in.
Oh, jeez.
And
Yeah.
me and my husband are so excited.
Again, I'm going to get you more excited because we're going to be cutting down our wait times by having a new process in place where someone else will take the history initially so that I can review it, just ask you a couple of questions, and then jump kind of right into the body and meat of the talk. So we will hopefully cut down on our wait times, and hopefully by the end of this week, we will have tied up having somebody new join us, which will drastically cut down our wait times. So I'm super excited to have that individual here, and we will know very, very soon.
Does an isthmocele automatically mean infertility?
No, not at all. It automatically means an increase in your chances of having an adverse microbiome and a lowering of your fertility chances, but it by no means equates to automatically being infertile. In fact, the vast majority of women that have had a cesarean section probably have some degree of isthmocele, and they still get pregnant. I will tell you, very interestingly, one of the guys that was in my fellowship when I was at Wayne State University in my REI fellowship, he was in the maternal fetal medicine fellowship. And this guy was super smart. He worked with Roberto Romero, who's also MFM, super, super, super smart guy, psycho hardworking, but that's another story. And this guy was from Quebec. His name's Emmanuel Boujol. So Emmanuel, you know what? We should get him on the show. He'd be great.
Here we go.
Yeah. Okay. I'll contact
Emmanuel.
Yeah. So Emmanuel just recently published a study with Dr. Romero saying that the way we do cesarean sections is completely wrong. So there is an outer muscle layer, let's say like from here to here, which we have to put together when we put together the uterus. And then there's the inner lining layer, which is your endometrium. So typically when we do it, we suture through the whole layer and we pull it back together, which creates that isthmocele automatically because it is flexing those two endometrial layers together and it's pulling them and kind of nudging them together. So you get intentionally that defect. What you are supposed to do, and what I've been doing for over a year and a half now, is actually just putting the muscle back together and leaving the endometrium unclosed so it seals off on its own, which then in large part should avoid the isthmocele effect. I think that's going to be a huge game changer for us and hopefully fix the problem. The only alternative would be to literally stitch it the other way and actually push it down. Maybe that's the way we're supposed to do things. I don't know. No one suggested that yet, but it could be the victory method. I might try that for a while and see what it does.
Victory method. I like it.
Cool. Like, just reverse the whole thing. It should, in theory,
pull it down.
Yeah.
Question. I had a polyp removal procedure. Should I start IVF on the next cycle of menstrual?
Yeah, why not? Your polyp is irrelevant to your IVF cycle. It won't make a difference at all.
Any advice with Asherman's? I've had repeated hysteroscopies, but still having implantation failure.
Well, I would want to see what your hysteroscopy looks like. I would want to see how thick your endometrium is. I would want to know your microbiome. I would want to know about your immune system. Did you do uterine PRP? There's a lot of stuff we would need to figure out for you. So those are the ones where I encourage people to contact me.
I'm 38. Do I have limited time for making embryos? I'm going to do IVF in 2 months.
Yes, you have limited time, but we're not talking months. I mean, it would depend on your AMH, but we're probably talking 2 years. So yeah, your time is limited, but it's not like, oh my God, I got to do it tomorrow. One of my favorite rants was this call I got from a fertility coach who told me about her patient who had gone to see a fertility clinic, a well-known fertility clinic, where they had told her she needed to do IVF that month or she would lose her chance and not be able to get pregnant. I was like, oh, like maybe her AMH was like rock bottom and plummeting or something, right? So I said, well, what was your AMH? And she goes, 13.
Oh, wow.
I was like, what? You mean 1.3? She goes, no, 13. I'm sure. Like,
Time of her life.
Double checked. I've got it right here. Like total, absolute lie. Like just an absolute lie. The patient was lied to so that they could score an IVF cycle. That is mental. I mean, it's totally, totally insane. It is immoral. It's unethical. It should never be done. That patient had loads of time. So it all depends on what your antral follicle count is, what your health status is like, what's your AMH, what's the rapidity of the decline of your AMH. These are all important factors for you. But are you going to go from 38, and huge success tomorrow to zero success in 2 months? That is virtually impossible in almost every single IVF patient. And if you look at the Israeli data, because there's studies on this, they showed that even for women with diminished ovarian reserve over the age of 40, a 6-month delay had a 0% impact on their success rate. 0. So whether you did it tomorrow or 6 months from tomorrow, you had 0 difference in your outcome. So there's never that much of a rush. People should not be forced into it. I see messages all the time from fertility specialists that are saying, oh, it's a waste of time to take supplements and, fix your nutrition and improve your health. You should just jump into IVF. That's actually not correct. You should fix your health. You should fix your diet. You should exercise. You should correct your weight. And you should take the supplements because it does make a difference in your outcome. No question. I mean, it's incontrovertible. The data is there.
Back to Instagram. What do you mean, Dr. V? This is for you for sure. If you want a better read or relate to PGT, review the PGT data, or when doing PGT with you on new embryos.
Yeah. So 2 things. Number one, I think we're probably a little more familiar with the data on PGT and what it means when you get an abnormal result. So if you have a segmental aneuploid, we will still tell you that it has a 24% chance of success. If you have a high-level mosaic, we'll talk about whether it's segmental or whole chromosome and what the chances of success are with that. If you have a low-level mosaic, if you have any other, like a complex aneuploid, we will talk to you about that. So number one, there's a lot of information and education we have that maybe not everybody else does. Maybe some places do, not disparaging anyone, but we have a lot of info on that. Number two, the depth of read that we get is double the minimum amount and way better than what other places are getting. So we are getting PGT-M level reads for PGT-A, which is incredible because that means the resolution and our ability to find abnormalities is better than most other places. Why? Because Adam's phenomenal at what he does, and we all love our Adam. So he's incredible. And Adam, I don't know if you're watching, you're probably busy with your kids, but we love you, Adam. You're amazing. So that's number two. Number three, and this is very, very important, is that we have the ability to actually put into your file and into your report whether it's transferable or not, even when it is abnormal. So we actually score that in there now, and we talk about that. So we're getting a better read. And the final thing, which is probably ultimately the most important, is that when you send off embryos for PGT analysis, some of them come back with no result. We call it a no result. They just couldn't make the test work. So Adam has had a 0.3% incidence of that. And it's getting lower and lower all the time as we do more and more embryos because he's not failing to get a read. Now, granted, the embryos are coming from us and my team knows how to do excellent biopsies, but we are getting excellent results from our PGT lab. What you don't see with other labs, like the PGT labs, is the same rate. They're getting like 4 or 5% and calling that normal. And we actually see an even higher rate. Same technician, same technology, same equipment, same everything. But when we send it to lab A, we get like a 10% fallout because we don't know what the test showed. And you can't rebiopsy. You're screwed at that point. Versus here, where it's 0.3%. So if you want top-notch PGT, tell them to send the embryos to us. We offer the same service for other clinics at less than what they're paying the big guys for. So we're more than happy to take that on.
Got something here for you.
Okay.
You might like it. You might not like it.
Okay.
Want to experiment with it?
Yeah, keep the camera on you. Go for it.
My famous TikTok doc.
Oh, I like that.
Yeah, I know.
Yeah.
Said the treatment for endometriosis
Is IVF.
is IVF. But she keeps failing me.
Oh, wow. Yeah. The treatment for IVF is never, the treatment for endometriosis is never IVF. I ranted about this a couple of weeks ago, and that little clip did pretty well. Let me rant on it again. IVF is never the treatment for endometriosis. Never. It is not a treatment for endometriosis. It makes endometriosis worse. There is nothing about the IVF process that corrects or fixes endometriosis. Does it improve your chances of success? Yes, but only when you include it in an entire protocol dedicated to the fact that you have endometriosis. Randomly just doing IVF on people does not improve their endo at all. In fact, it makes it worse. So for the love of God, no one should be telling patients that IVF is the cure for endometriosis. It's sure as hell not the cure. It definitely makes it worse. There's studies showing that it makes it worse. It can make endometriomas bigger. It can make new endometriomas occur. It can cause recurrences of endometriomas. IVF is not good for endometriosis. What is it good for? It's good when you use it as part of an entire protocol where you bank embryos. You don't do an idiotic fresh transfer for the patient because that makes zero sense. You do a frozen embryo transfer after you've suppressed, hopefully operated, optimized everything, adapted to the immune problems, treated the patient with natural substances that are anti-endo and beneficial for the patient, and come up with this nice big holistic approach to correcting the patient's endometriosis. Randomly doing IVF for people is going to fail them. And that's egregiously unfair to the patient. No one should undergo that. No one. If your doctor tells you IVF is the treatment for endometriosis, turn around and walk away immediately. It is not the treatment for endo. It just isn't, period.
Dr. V, it seems that a lot of people were told the same thing.
Really? Wow. Yeah. I will never say that to you, ever. Ever. I'm never going to say that to you. Never have, never will. IVF does not treat endo. It makes it worse. IVF makes endo worse. I can show you a dozen studies. It just doesn't make sense. And a whole thread on consensus that has that.
Any recommendations for men who have NF1 wanting to do IVF with a geneticist? With a gene test? With a gene test?
Yeah, just do it. Yeah, just do it, and then we do PGTM, and we find out if you have neurofibromatosis. That's easy.
Easy peasy, guys. Don't worry. Hey, goats.
Yeah.
I'll take that slang all day.
I'll take that slang all day, too.
Doctor doesn't want me to do endometritis test of cure while I'm suppressed on Lupron and Letrozole because lining is too thin.
Yeah.
Is that true?
Well, yes. If you're doing a biopsy test, which is useless, by the way, you definitely shouldn't do it while you're suppressed because it has a risk of scarring. So I wouldn't do that. And it probably wouldn't be accurate. And if you wanted to do it via menstruation, you can't because you're suppressed. No one should ever do a biopsy test to look for endometritis, number one. And number two, if you are doing that, definitely don't do it while you're suppressed. It would be harmful.
How long should you treat with rapamycin?
8 weeks.
I'm 32, 3 euploid transfers, and they all failed. Could silent endo be the cause? We had an immune protocol? Yeah, immune protocol probably.
Yeah, sure. Silent endo could be the problem. Of course it could. Microbiome, deeper immune problems, endometriosis, adenomyosis, poor embryo transfer, inadequate progesterone levels, bad sperm quality, low vitamin intake. There's a million different reasons. Funny shaped uterus. I had another patient drove all the way here from New York just to do an SIS with us.
Big drive.
On the weekend. Okay. I said, no worries. Take your time. I'll wait for you.
I'm here.
Show up. We'll do the test. Did the test and looked at her uterus. I'm like, this is the letter T. It's like this and that. And I said, you need surgery. She's like, no one ever said anything to me. I've done all these IVF cycles. I'm like, you need to fix that uterus. All the time we see that. We see so many patients time and again now. I have to tell everybody I'm talking to, loads of second opinions. And every single time I got to tell patients the same thing. Like, you need a 3D saline infusion sonohystogram, and I need the images from that 3D saline infusion sonohystogram in order to be able to interpret it. And they go, well, I had one. They said it was normal. I'm like, yeah, no. Because half the time they tell them it's normal and it's a T.
No way.
And
Really?
I'm not saying T for Tarek. I'm saying T for abnormal uterus.
T for Tarek would be phenomenal.
Yeah. Great. Yeah. This is not good T.
This is not part of the program.
Y shape, T shape, all sorts of funny things. And they're never told. And they're like, well, why wasn't I told? I don't know why you weren't told. Like, you should have been told. But a lot of time the doctors don't even know what they're looking at. They don't look for that because they don't think it's an issue.
So let's say somebody is going to go and get this SIS, right? They're going to go inside and see what it is. What should be the thing every patient asks? So should just say, what is the shape of my uterus? Should everyone just be asking that? First go question, what's the shape? Or should they say, is it good? Because I think this is the confusion happening.
That's a good little clip for us.
We
should have a whole bunch of pictures. T shape, Y shape, septate, whatever, right? Yeah, you should be saying precisely to the doctor, what does the inside of my uterus look like in 3D? Because a lot of places do it 2D, which is useless. What does the 3D picture of my uterus look like specifically? Am I a T, a Y, arcuate, septate, bicornuate, like whatever? You want specifics. And if they say, no, it's fine, say, no. I want a picture of what the inside of my uterus looks like. And if it's really narrow up the middle, you got a problem right off the hop.
See, guys, I did that for you guys. Dr. V, I did letrozole 7.5 milligrams day 2 to 6. Will it work on my first time or will it take more cycles? I have PCOS.
So first of all, I've never done day 2 to 6. We do 3 to 7. But the outcome from the Legro study versus Clomid, which is the largest randomized controlled trial for letrozole I'm aware of, showed that over 6 months of use, you had a 27.5% chance of having a live birth. So is it likely to work on your first try? No, not at all.
Dr. V, I heard you're opening up a clinic in Woodstock.
Yes.
Is that true?
It's true, but it's a work in progress because we need a doctor. So if you have a doctor for me, I'd be more than happy to engage.
Just a straight up question. What about 37 years old?
Love 37 years old. Great age. Had a blast when I was 37.
Oh, me too.
Yeah.
37 was like yesterday.
Yeah, 37 was great. You know what? 37, believe it or not, was my second year of full practice.
Oh, wow.
Yeah. And I was just starting and I was still in Leamington and we were looking for a spot in Windsor.
Oh, wow.
Yeah. And it was the first time I actually made enough money to not worry as much. It was a good year.
37.
I like 37.
That's nice. 37 is good.
Not a problem for fertility though. It's fine. 37 is good as long as you have a reasonable AMH and your partner's sperm is good.
Hi there. Insulin resistance remission, confirmed ovulation every month for 8 months.
Okay.
Endo specialist said to take metformin to help with endo inflammation and PCOS.
Yes.
Thoughts?
Yeah, it's
First
great.
time meeting endo.
Yeah. So metformin actually is beneficial for endo and for PCOS. So it's very reasonable. I'd also take supplements, inositol. We use a great product called inofolic. So you can use that if you want, but you can use any other inositol mix. You can use NAC, resveratrol, curcumin, ALA, and coenzyme Q10. So there's some natural stuff that'll mimic the metformin without any of the side effects. If your weight is high, you should consider dropping your weight, whether you use a GLP or something else to do that. That's also a worthwhile consideration. So there's a lot of different ways to tackle this. But there's no question that metformin is beneficial for both PCOS and for endometriosis patients. That's been shown in many studies.
Big T and Dr. V.
Big T. Oh, wow.
I like that.
Yeah,
I'm good with
Big
that.
T.
Yeah, Big T. Can you provide the difference in target population for IVM and IVF?
So anyone can do IVM. The thing that's cool about it for us is that we realize that women who are older or have diminished ovarian reserve have lower oxygen concentrations in their ovary. And the theory is that it's that low oxygen concentration that is causing the problem with the egg quality. So in order to improve the egg quality, you need to get the eggs out early and mature them in a normal oxygen concentration, because then in theory, the eggs will do better. So here's the catch. It's very difficult to mature eggs, but we figured out how to do it better than everybody else has been doing it, number one. And number two, instead of giving patients loads of meds, pounding them with these high doses that are super expensive and of zero value because you just barbecue the eggs anyways, we actually figured out how to do this with zero meds. You don't even need a trigger shot. You show up and we retrieve your eggs. And then we mature those eggs in the lab in normal oxygen concentrations, and then we fertilize them. That process may be improving the quality of the eggs. So we're going to find out. We just did the first case ever, not just for us, but in the world, I think. And so we're really excited to see what that shows.
Dr. V and the King T, smiley face.
I like that.
I love that.
I like the whole rollout. And
yeah, well,
that was, yeah.
It's part of the reading skills here.
Yeah.
See, sometimes I can read the words right.
Yeah. Yeah.
If I started with your clinic in November, realistically, when would I be added to the government funding list for ER? I waited so long at my clinic, but they aren't endo friendly.
Immediate. As I mentioned at the start of the show, if you need to do an egg retrieval, we want you to do an egg retrieval because we still have about 75 spots left. So come for your egg retrieval in January, February. And if it's going to be a long time to get you back in, let the office know that you're raring to go for IVF. And we will do our best to process that as quickly as we can. Don't all come crashing in saying me first, but let the office know you want to do IVF, and we will do our best to accommodate you as quickly as possible. And bring your friends too, because we have enough to accommodate them as well.
Hi, doctors. I got a 2-point question.
Okay.
How many hours of progesterone do you need for a day 5 blast?
120 to 144. It doesn't make a difference, but we usually use 120.
Secondly, can you explain why the Receptiva DX isn't a good test?
Because studies show that there is no benefit to the Receptiva DX. They actually have 2 studies that showed that pre-testing with Receptiva DX made no difference to the outcome. Now, I don't think those studies were probably well done because they did not actually include a full endo protocol for those patients, but it's not useful, so we don't do it. And here's the thing, Receptiva DX, which costs, I think, $650 US, don't quote me, but I believe that's the cost of the Receptiva DX, has the exact same sensitivity and specificity, according to their website, that a questionnaire developed by an Israeli group has, which is free. So you can literally answer 23 questions on the internet and figure out if you have endo with the exact same accuracy as paying $650 to Receptiva DX. Why would you pay $650?
I opt for the survey.
Yeah. here's what you do. You take 200 of the 650 and you put it in the bank. You take another 200 of that and you do something fun with it, like a really extravagant dinner with your partner. And you take the remaining 250, this is US dollars, by the way, and you give it to an infertility charity, which gives you back 50%, hopefully, in your taxes. So you actually get back another $125 that you saved. And now you feel good about yourself. You had a great meal and you got the answer that you wanted. Plus, you saved $325 ultimately.
I feel you kind of missed the most important option in there.
Yeah. Brownies
is
for us.
Brownies for us.
Brownies for us.
Yeah.
Okay, take $10 and buy us some brownies.
There we go.
Yeah, or just bake them for $5, whatever. But I don't want any of that $650. But I do want you to get it because it's a waste of money. Don't do it. And Dr. Lessie, who invented it, is a super nice guy. Very gentlemanly, very smart guy. I love the guy to bits. Nothing against him at all. The test doesn't work.
Can you speak more on DNA fragmentation?
Sure.
My husband is at 29%, and he was deemed normal because he's under 30%.
No. So the cutoffs are optimal under 15. You're kind of okay under 25. 30 would be considered high by anybody. There are different tests, there are different standards, but we don't take 30. So DNA fragmentation, if you remember, the DNA is like a ladder that's twisted. So if you think of those side panels that hold the rungs, when there's fractures in those side panels, that's DNA fragmentation. It's breaks in the strands of the DNA. So when there's breaks, the problem is when the chromosomes all line up to divide in an embryo that's rapidly dividing, it's unstable. And so pieces break off and the chromosomes don't line up and you end up with mistakes, and that's how you get miscarriages. So DNA fragmentation destabilizes embryonic DNA, and that's not a good thing. At 30%, you've got a really high margin of that happening. And studies clearly show that when your DNA fragmentation is up at that range, you have a much, much higher rate of having a miscarriage. Very easy to test for, quite reliable with the testing, very easy to fix as well. But at that rate, I would not be going forward with anything, even natural conception, because there's simple ways to fix it, and you should be doing those before you try.
Hi. After LIT treatment and it seems successful through Fertiliosis, how long does this last? Is a higher percentage yield a more favorable outcome?
Yes, more favorable outcome. And generally speaking, we talk about 6 months. So you've got about 6 months before you're going to fade out a little bit on the LIT. So then you would need a booster LIT.
Hi, Doc.
Hello.
Dr. Victory.
You're on me instead of you.
I'm on you. I'm meant to be on you.
Oh, okay.
What day are you in the clinic next?
Oh, interesting question. Thursday, Friday, Saturday.
Asked by a certain Jenna Vick.
Oh, hi, baby. Well, she can't be. Jenna Vick?
Jenna Vick.
She can't be up right now. It's 3 a.m.
Jenna Vick is
At
asking
2
this
a.m.
question. It could be an imposter.
It better be an imposter. It better not be my Jenna Vick. I am in the clinic Thursday and Friday and Saturday. Sunday I am not because I'm on call.
What is the best FET protocol for those with endo?
Ours. It's on our YouTube. It's famous now. So Lupron and letrozole for 3 months, lots of natural anti-endo supplements, double progesterone, high dose, and an immune protocol. And a transvaginal ultrasound guided embryo transfer if your uterus is flipped over, which virtually no one knows how to do but me and Shireen and a handful of others across
Is that
North
right?
America.
Rare thing.
Yeah. I'm super proud of Shireen though. She nailed it.
Hey.
She's good with embryo transfers. Really good.
Dr. V, I have a bicornuate uterus.
Yeah.
And PCOS.
Okay.
I've had 2 failed transfers and I'm going for my 3rd FET. What protocol would you use?
Letrozole protocol has been proven to be the best for PCOS women, so I would do that. Depending on how difficult your uterus is to see, I would consider a transvaginal ultrasound guided transfer. Make sure you're on double progesterone. Make sure your thyroid's good. Make sure your vitamins are excellent. Make sure the endometrial thickness is appropriate, and make sure they're putting it in the right place. Some people might bump up against the septum in the middle or the bifurcation and think that's where they're supposed to put the embryo, but they can't. They got to go up into one of the horns, depending on which one is the bigger horn with the more plush, thick kind of endometrium. So that's like a real specific case and not necessarily an easy one. So make sure they know what they're doing.
Hello, amazing doctors.
Oh, sweet.
Found out that my endometrioma disappeared after supplementing with NAC for 6 months. Was also pregnant for 10 weeks. Any association?
You know, someone brought that to my attention the other night, so I should talk about that. Or yesterday. Yesterday? Yeah, I think it was yesterday. So they brought it to my attention saying that they had read a study that showed that being on NAC shrank endometriomas. And I was like, what? That doesn't make any sense. So I jumped on Consensus and I looked it up, right? So sure enough, there are studies that have shown that being on NAC can shrink endometrioma. So first off, I'm like, there is no way, this just doesn't make sense, because nothing shrinks endometriomas. Not even Lupron shrinks endometriomas. So I said, there's no way that this is true. So sure enough, I look it up, and in the abstract, it's like, yeah, highly significant, like 0.001, p less than 0.001. Like, wow, did I get stumped? Like, is this something I don't know? So I pull up the article and I look at it. And it's a 3 millimeter difference in a 3 centimeter endometrioma, which is clinically irrelevant. Makes no difference.
Still
whatsoever.
huge.
Yeah. So listen, if you had an endometrioma, it would not have disappeared because of NAC. You may have had a hemorrhagic cyst, but you did not have an endometrioma. It's impossible. They don't go away.
Lucky Victory.
Uh-huh.
I did letrozole 7.5 milligrams, day 2 to 6.
We did that one.
We did that one, yeah. Can you still do an IUI or IVF with an isomycel?
Can you? Yes. Is it going to be as successful? No, but you can still do it. Sure.
What test to do if I have 2 recurring miscarriages at week 6?
DNA fragmentation, vitamins, thyroid tests, thyroid antibody levels, microbiome, immune, thrombophilia, karyotyping, 3D saline infusions on histogram, lots of testing you can do. Some people hold genome sequencing, depends on the rest of your history.
You should bring Adam on the show, is what one comment says.
Is it from Adam?
It's not. It's from somebody else.
Adam is so bloody smart. I feel like an imbecile next to Adam. Now, hopefully he doesn't watch the show.
So he never finds out.
Adam is just next level intelligent. Adam is like my kids. All 3 of my kids are genius level kids. And Adam is like my kids. Like he is just crazy smart. Yeah.
Dr. V, how much does a paid IVF cycle cost with your clinic? Money bags.
$12,745, which includes all the monitoring, everything you need for your retrieval, except for follicular flushing if needed. It does not include that. That's $500 extra, but not everybody needs that. Most people don't. It includes 1 year of storage. It includes any tricks we need to use, like time-lapse or embryoscopes, ICSI, blastocyst culture, assisted hatching, all of that stuff. And it includes monitoring and preparation and instruction and teaching and everything for both the IVF and for your first embryo transfer. And it includes your first embryo transfer as well. So all of that is $12,745, which I'm fairly confident is the cheapest anywhere right now. So we do some of the best work in the world for some of the lowest money in Canada.
901.
Let's give him one more.
Let's give him one more. No question, just big love from myself and baby Brownie.
How's baby Brownie, Heather? I hope baby Brownie's doing well. Oh, I love Heather. She's the best. Those brownies are just
phenomenal.
They're so freaking
phenomenal.
Next level brownie. Like,
I woofed down the last batch she FedExed me. I couldn't handle it. They were so good. I was like, do I eat dinner or do I have Heather's brownies? I'm having Heather's brownies. Like, it's that good.
Dr. V,
One question.
the ultimate mind bending question.
Oh, bring it.
It's not that big. Unnecessary hype. Kings of the fertility world.
Oh, nice. Good start.
Right?
Love
Great
that.
start.
Yeah. Yeah.
Does it matter? Metformin versus Ozempic versus tirzepatide for fertility successes?
Tirzepatide probably has the best impact on weight loss and metabolism regulation. Then you would be looking at Ozempic and then metformin. There's no question that the weight loss and anti-inflammatory component of the GLPs is much stronger than what you get from metformin. Now, if you also have endo, I'm not aware of any GLP endo data. Maybe there is some, I just haven't seen it yet. But metformin does have endo data. So it would depend on whether you're PCO and endo or not. But otherwise, the GLPs are way stronger than the metformin is. And I am a huge fan of the GLPs, enough that I'm on a GLP.
We'll end it with this one. Hi, guys. What is the cause of my recurring miscarriages? Heartbeat at 7 weeks. Then by 11 weeks, it has disappeared and the sac is collapsing. Please help.
No way to know just based on that. I would need to talk to you and get your full history. So feel free to DM me, but I need more details to be able to answer it. It could be a single gene defect, like an essential gene variant, microbiome, immune problems, DNA fragmentation, hormones, thyroid, thyroid antibodies. Something as simple as vitamin D levels can cause this kind of problem. So shape of your uterus can cause this kind of problem. So I would need to see what's wrong. You would need a thrombophilia screen, karyotyping. Like, there's a lot of testing that goes into figuring this out. And I will happily tell you that the vast majority of clinics and doctors do not know how to do this properly because they're not investigating everything that they can investigate. We just did a case for a family that had multiple losses. We did whole genome sequencing for them. And sure enough, we found out they have a whole genome sequencing problem. They have an essential gene variant that we now need to address by specifically looking for that gene. And now we'll be able to get them pregnant, hopefully, without having the problems they were having before. Huge difference in their outcome. Huge. Something they never would have known. How many people even know about whole genome sequencing? Like, very, very, very few. So this is something that we've been doing now for a while, 8 months now, 7 months, and it's phenomenal. And it's making a difference in people's lives and in their outcomes. Time for the show to close. Thank you all for watching. Huge love from Tarek and I. We appreciate you guys being here. Can't thank you enough for watching. Please go to our Instagram channel, where we would love it if you would turn that lawyer upside on his head by making that video go viral. So please share it to as many people as you possibly can. Share it to all your friends and family. Share it to as many wonderful other people as you can, especially lawyers. Make sure that you comment on it and like it. And I think that one needs some sprucing up because this guy had the audacity to claim that doctors don't have opponents. I got God, biology, time, exhaustion, everything you can imagine as an adverse, horrible adversary right there in front of me. And this guy had the audacity to claim that there wasn't one. So on behalf of Tarek and myself, have a wonderful night, guys. Thank you for watching Fertility Fact or Fiction. We will be back next week with another show, and we may be making oatmeal on the show. We'll see. Have a great night.